Give me an AP. AP means front back view. We're going to use the X-ray machine to see the spine. It guides my surgery. Perfect. And lateral. All right, and a little bit to the patient's shot. Left. Shot. All right, I like that. Shot. Now let's get an AP and verify we are in the right spot. Luis, go ahead and inject. Neck is fine. Yeah, neck is perfect. It's supple. All right, so we're a little bit off to his right, so I overcorrected. Let me go back and redo it. So where the needle is right now, I would not proceed normally because it's too far, in my opinion, to the patient's shot to his left. We were too far to the right. Let's get another picture. Hopefully this is the right spot. Shot. That looks better. Again, there's some rotational stuff going on. Maybe I need to bring it back just a little bit to the shot. I always try to get the positioning as perfect as possible. And the reason for that, shot, is you're never going to be perfect, but you want to be as close to perfect as possible to get the best result for the surgery, for the patient. All right, that's really perfect. Show us the midline on that X-ray. We want to be in the midline when we enter the front of the disc. Yep. And there's two muscles that run along the side of the spine called the longus colli, L-O-N-G-U-S colli. And you want to go between them. And when you do that, there's about a centimeter of space between the two muscles' medial borders. If you could stay out of those two muscles, it's much better. Shot. All right. We're going to do a discogram. Shot. And there's the tear. Show us the tear. That's what we're looking for. In the back of the disc, there's an annular tear, or tear in the annulus fibrosus, and it allows the dye to leak out, and there's a herniation. So that's what we're here to fix. All right, stay in the lateral view. Some of the dye is also leaked out in the front. It's just in the retropharyngeal space. We're not interested in that part. That's not what we're here to fix. All right, at this point, I'm happy with my entry point in the skin. It's on the right side of his neck. We're going to lose our first drop of blood for the whole surgery right now. Most likely, we'll lose one drop this whole surgery. And that will be the drop of blood we lose. This is a bloodless treatment. It was first developed, the endoscopic part, by the Koreans, the South Koreans. And the South Koreans, Dr. Sang-Ho Lee, that's who trained me, and Dr. Gun Choi. I'm going to make a 4mm incision right where the needle enters the skin. Okay, 4mm, that's all I need. Let's drop number 2. Shot. Okay, while I'm doing this, let's close the window down on the left so it doesn't get my hands radiated. I'm wearing special gloves, radiation protection gloves. They do not shield 100%. They reduce the radiation by maybe 30 or 40%. All right, shot. I'm also using a guide wire. I'm taking the needle out, leaving the guide wire. I'm going to then place what's called a dilator. Notice the tip is pointy. It doesn't cut anything, it just spreads tissues open. Specifically, the fascia in the neck, which is the connective tissue in the neck, as well as the front of the disc called the annulus. Shot. You could see the tip of that dilator. As I go in, I twist it, because otherwise it can sometimes get kind of caught, shot, on the tissues, and it's better to twist a little bit as you go down just to free it up from the surrounding tissue, so you don't drag anything. Like if you catch a vein, you don't want to tear the vein, so you twist and it gets past the vein. Kind of like wiggling through. All right, looking good. Now I want to verify on the AP view that we're in the middle. We're using the lateral side view to navigate down to the disc. Now we're going to verify that we're in the middle of the neck with our AP view. Thank you, Luis. Go ahead, put it there. Shot. All right, so look at the tip of the dilator. It's in the perfect middle of the spine. Show us the middle of the spine there. That's correct. And we're right in the middle, at the front of the disc. We're going to pass through the disc now. Lateral. I use the X-ray to do that. Now, Jordan, you're on the pulse mode, right?
Correct, sir.
So as I enter the disc, I'm twisting again with my dilator shot. I want to watch my guide wire tip. I don't want it to go any further in. Shot. It was sitting in the herniation, in the tear. At this point, I'm taking my guide wire out, and I'm going to advance my dilator through the disc. Now, people ask me, does that hurt the disc? The answer is no, it does not. It hurts the disc no different than you hurt a swimming pool when you dive in the water. You don't hurt the water. The water spreads around you, and then when you're done swimming, you come out, and the water is back to where it's supposed to be. We're literally going through a material that's almost completely water, which is the nucleus. And you can't really hurt it. So now I'm bringing my tube. We're going to do the whole surgery through this skinny little tube. And this system you're watching is FDA approved. It's actually manufactured by a company called Richard Wolf out of Germany. It's been FDA approved for 30 years, 25 years maybe. Sorry, about 25 years. It was developed, I think, by Dr. Sang-Ho Lee, working with Richard Wolf. All right, here we go. We're going to advance the tube. You can see the tube at the beginning of the disc. Show us that, Jordan. Right there, and we're going to advance it down. Now I got to watch the dilator to make sure it doesn't go in. No, we're fine. He doesn't really have a collapsed or scarred disc. Everything's moving through the nucleus nicely. Any questions, Henry?
At this moment, no current questions.
Let's show the audience how is it that a herniated disc can cause so much neck pain. All right, welcome back. You can see from our video that it's inflammation, which is painful, happening within the back of the disc. That's where the pain comes from, that causes neck pain, headaches, even arm symptoms like arm pain down into your shoulders. We're going to go down the tube. The tube is going to allow me to get all the way down to the back of the disc. And there it is. You see that? Now, if you're a One of our followers who watch a lot of our surgeries at Deuk Spine Institute, you know that that view right there is not a great view. That's kind of like a little bit blurry, but that's because this is a fiber optic scope. And if you look really carefully, you can see 5,000 fibers. You guys see that? Little dots?
Yes, we do.
See if I can. Anyway, I'm going to try to clarify the image as well as I can. There we go. Now there is a rod lens system, but it's much bigger. And because it's bigger, I don't want to use it because it can do damage to the disc. At least that's what my concern is. I don't have any proof that it can damage the disc, but the reality for me is, why change something that isn't broken? If it's working, keep doing it. If there's no problems and it's a perfect system, keep using that perfect system. All right, Henry, let's show our audience how we fix these disc herniations that we're doing right now.
Copy that.
All right, welcome back. Maybe Thursday, Friday.
Yeah, we'll be
No, I mean you can take those days. So I'm Dr. Ara Deuk-Majan, CEO and founder of the Deuk Spine Institute. I'm here with my team here at Deuk Spine and Surgery Center of Vieira. We are in the process of fixing the first of 3 discs in a patient who traveled from Trinidad. He's been watching our surgeries. He could go anywhere in the world. He could have an artificial disc put in if he wanted, made out of metal. But he's smart. He did his research. He found the very best treatment in the world for a herniated disc in the neck, which is this surgery right here. And as I said earlier, the reason I'm doing this surgery is because it is the best surgery. It is the best treatment, okay? At Deuk Spine, we are able to do any treatment in the world for the spine. Any treatment available. Artificial discs, we can do. Let me see if I can improve the focus just a little bit. I don't know that did. We can do fusions, artificial disc, laminectomy, foraminotomy, you name it, we can do it. The reason we do this particular surgery is it's the safest of all the surgeries that can be done. The reason we do surgery is there's no other way to cure pain and radiculopathy or radicular symptoms from a herniated disc in the neck. There's just no other way. Your body will not heal it on its own. Everybody thinks it will. Physical therapists will tell you your body can heal it because that way you go to physical therapy and you pay them and they make money. Okay, but the reality is if you're having a herniated disc that causes symptoms like pain, the only treatment that works is surgery. And there's a couple of surgeries that really work and get rid of your symptoms. One of them is ACDF fusion. The other one is this procedure, the Deuk laser disc repair. The difference is we're not fusing, we're not putting metal, we're just going in like a ninja. We're removing the offending painful area, which is the herniation, and cleaning up the tear. These are all herniations that have been coming up, by the way. And with fusion, the reason why we do fusion is the doctors that did fusion, that do fusion, they were not trained on this new technology. This is a newer technology than fusion, and there are only a few surgeons in the world know how to do this. Cervical endoscopic surgery, probably at most 5 in the entire world. It's not easy. It took me years to develop the proper technique. It's obviously we're going through the front of the neck, so it could be high risk if you are not where you're supposed to be. If you're a millimeter off, you can kill the patient or worse. And it requires very special training, which I got, okay, overseas, because nobody in the United States was doing this. So the real question is, why is nobody in the United States doing this? And number one, they weren't trained to do it. They don't have access to the training. You have to travel. And number two, the United States is extremely corrupt when it comes to spine surgery, okay, spine care. It is controlled by companies that want surgeons to be putting metal in people's necks, because that's where they make their money. They make tens of billions of dollars a year, these companies selling metal. Metal plates, metal screws, metal cages, plastic cages, biologics. And they have now infiltrated our educational system where surgeons are trained, and they control the educational platform because they own the surgeons that are basically training our next generation of surgeons. And by doing that, they ensure that their products will be used and implanted in patients for generations of surgeons to come. Okay? It's a real problem for patients, because patients aren't aware of this. And we're actually in the process of raising awareness. One of the ways we do that is through these live streams, so people can watch the live stream and ask questions and hear me talk and learn. Any questions?
Yes, we have a question from Mike on YouTube
Sure, Mike, on YouTube.
asking, can scar tissue and bone spurs be removed with the surgery in
Yes.
the lower back?
Yes, scar tissue and bone spurs can definitely be removed with this surgery. As a matter of fact, right here that I've been removing for the last minute is scar tissue, and that's a bone spur right there. The golden color that I'm just doing right now is a bone spur. So yes, this is scar tissue right here, the whitish stuff. It's herniation mixed with scar tissue, okay? Now, the question is, do you want to remove scar tissue and bone spur? And I don't know the answer to that. I only go and do surgery on something that will help the patient feel better. So if you're not going to be better by removing scar tissue and bone spur, I'm not going to recommend surgery, okay? The key is we are targeting symptoms. I'm almost done on this disc. I've got about a minute or two left. Man, there's a big tear back here. You see that? That there is a tear. You could see some of the posterior longitudinal ligament fibers running left-right. There's still some scar tissue here. All right, there we go. We don't have to get all of it because, like I said, scar tissue usually doesn't cause symptoms. It can, but I only remove it when I think it's causing symptoms. Now, what kind of symptoms does scar tissue cause? Typically, it'll push on the spinal cord or the nerve roots and cause myelopathy or radiculopathy in the neck. Or in the lower back, it can cause radiculopathy, which is, you know, leg pain. Look at that herniation, just came out of the foramen. You see that?
Yes, we do.
That was sitting on top of the nerve root. Now, that's not scar tissue, that's a herniation. All right, almost done. So, yes, we can remove scar tissue. Yes, we can remove herniations. Yes, we can remove bone spurs. But again, I don't do surgery to remove bone spurs. I do surgery to get rid of neck pain, back pain, or to get rid of leg pain, sciatica, or to unpinch a nerve that's being pinched. There's a herniation right there. You guys see that? It's big. I'm going to go try to grab it out. I'm going to use a grabber, little pituitary rongeur, very skinny. Got it. All right, take a look at this. Let's put it here against the blue. You guys see this, Henry?
Yes, we can.
So I just grabbed it out, and you can see it looks big, right? But it's only about 3 millimeters. See it?
Yes, we do.
Right there, okay? The problem is herniations are not one herniation like this. This is one herniation. Herniations are really made up of about, I don't know, 30 to 50 pieces on average. And you got to remove as many of them as we can. I'm going to go look in there one more time. I'm going to take one more look, just see what's going on in there. Make sure we're done. Now, some patients, I need the scope view. Some patients think that their MRI is going to look normal after surgery. It's never going to look normal after surgery, ever. We don't do surgery to make your MRI appear normal, okay, ever. That's not the goal. Your MRI is going to look about the same. And that's because we don't treat MRIs. We treat patients. And what that means is, if MRIs could tell you definitively what's causing a symptoms, then nobody would have back or neck pain, would they? Because all these doctors would look at your MRI and say, oh, there's the problem. The problem is that doesn't happen. The doctors look at the MRI and they have no clue what's causing your back pain or your neck pain, because the MRI will never tell you where pain comes from. Patients do. And that's why the physical exam is the most important. And at Deuk Spine, we have what's called the Deuk Spine Exam. We have a pain map called the Deuk Spine Pain Map. Thanks. There's the foramen, by the way, and we just took that big herniation out of there. Little bit of bubbles, air, in our irrigation. Some people ask me, why doesn't the laser catch things on fire? The answer is it's underwater. We're constantly running water through, called irrigation, and the water is cold. We keep it refrigerated before we use it. So it cools the tissues so they don't burn. There's a lot of misinformation out there about lasers. All right, I think we're done. Let me go look the other way. And their use in surgery. Doctors who don't know how to use the laser, they're always bad-mouthing the laser because they don't know how to use the laser. And they're losing business to patients who want better surgery and they can't provide it to them. All right, any other questions?
At this moment, no current questions.
Okay. All right, we're pretty much done. I just want to do one more peek. Again, this is the foramen on the patient's left arm, and it looks good. I don't see any more herniation. We're done here. I'm going to irrigate this back of the disc with some irrigation. It has a little bit of antibiotic, and the purpose is to wash out any loose pieces of herniation. Also, to prevent infection. All right. Now, I'm going to tell you, when I trained on this endoscopic technique with the South Koreans, Dr. Sang-ho Lee, Dr. Gun Choi, they were only able to do one disc at a time in patients. And I developed a technique to do more than one disc, because if you have 3 discs that are herniated and all 3 are causing problems, do you really want 3 separate surgeries? No. Thank you. You want one surgery to fix it all. Now, of course, if a patient wants 3 surgeries, we'll do 3 surgeries. But we want to be able to offer the whole treatment in one surgery. So we do that, and because I developed a multi-disc technique to treat all the discs that were symptomatic, we've been doing that now for 18 years. All right, now I'm going to count 2, 3, 4, 5. I'm going to go down to 5, 6, and then we're going to come back up to 3-4. Okay, that's just the way I do it. So, I'm going to use my x-ray machine to keep track of my equipment, pressure on the Raytec, and I'm going to bring this tube out. I want to leave I want to leave my dilator in there, but I want to take the tube out. Perfect. Now I'm going to hand the tube off to Luis. Keeping an eye on my dilator. This is the hardest part of the surgery, in my opinion. Moving from one disc to the next. All right. So remember, we're going to go down one disc to do the next one below first. So to do that, we're going to get some x-rays, and we're going to be very careful as we do this. If there's any questions you have, type them up. I'm happy to answer them. Coming out, I can feel with my fingers when I'm out of the disc. There we go, we're out. Okay, I'm sitting in the front of the vertebral body of C5. I want to verify I'm in the midline, because sometimes you can get pushed to the sides by this esophagus and trachea. And we're a little bit to, maybe a little bit, just a tiny bit to his left. So I'm going to come back. I'm going to slide down. And let's get one more shot. Hold on. All right, still in the middle, lateral. And at this point, I'm happy with the front back. I'm in the middle between the longest coli muscles. I'm going to check my position on the lateral view. Still need to come down a little bit. So 2, 3, 4, 5, 6. Everybody agree we're doing 5, 6 next, correct?
Yes, sir.
So I'm coming down, and frequently there's like a little bump here. Okay. I like that on the lateral. Now I got to verify it on the AP. That bump is called an osteophyte or bone spur. You can see it on the bone above. Quick shot. Let's get the head straight. Hold on. Is that straight? Looking up. Don't move. Shot. Damn it. Jordan, you got to be straight too. You know that. Shot. Come on, Jordan. I need you here right now. Shot. Lateral. All right. So I had to make some adjustments, and I'm not done yet. I've got to verify. All right. So we slipped off. You can see that. Shot. Let's check again. AP. Shot. Okay. And shot. That's perfect. I'm going to advance the dilator through the front of the disc called the annulus. Shot. 2, 3, 4, 5, 6. Always check your levels, because you could be surprised one day. Shot. I don't know. His neck feels a little bit tighter. Is the muscle relaxer wearing off? Shot. AP. I may need it for the last level. So I give him a little more now so that it wears off by the time we get to the last level. All right. No. Lateral. We have one more after this. All right. So at this point, hold on. I'm going to clean the dilator out. It has a hollow center. I want to inject some dye. Shot. Perfect. We're going to do what's called a discogram. And the reason we're doing this is not to see if the disc is painful, because the patient can't respond. It's called a chromodiscogram. The purpose is to see the tear. There's the tear right there. You guys see it?
Yes, we do.
All right. That's what we're here to fix, that tear. and remove the herniation stuck in the tear. The other way to do this, folks, is to open them up with a big cut and, move all the muscles and tendons and blood vessels, esophagus, trachea. Get down to the disc, take the whole disc out. Show us the disc that we would have to take out. It's called an ACDF. We take the whole disc out just to get this little thing in the back. So the Korean said, why destroy a perfectly good disc when the problem is in the back of the disc? Very smart. I actually thought the same thing for years. Why are we destroying the disc just to get to the herniation? But I didn't know how to get to it on my own until I went and learned from the Koreans that they were doing it. They were smart. They figured it out, and they do it endoscopically. What I do differently is I use a laser, because a laser is safer than just sticking metal instruments down there and scraping away. Why don't they use the laser? I don't know. It's a great question. I mean, I've published my results in PubMed. They have an opportunity to read them and do what I do, but I think they have a lot of pride, and they don't want to admit that there's a better way. And that's fine. No skin off my back. We just do what's best for the patient. All right. Just about there. Well, we're going to take a look and see what's going on down there. I think we're locked in the back. Any questions?
Yes, we have a couple of questions. This next one coming from Renz on Facebook.
Before we do that, let's show you guys how we're doing the surgery. Give me a marker. You guys see this incision here?
Yes, we do.
This is a 4mm incision. You see that?
Yes, we do.
If I was doing an ACDF, which we do a damn good ACDF, I've done 1,000, the incision would be like this. From here to here. We'd have to move over the salivary gland. We'd have to cut the strap, through the strap muscles and the fascia. It's a much more invasive surgery, and because of that, ACDF and artificial disc, same. Their complication rates are almost identical. ACDF complication rate is 50%. That means 50% of patients having ACDF, which they do hundreds of thousands a year in the United States alone, and they're putting metal in your neck, those ACDF complication rates are 50%. That's the published data, 50%. That means every other patient will have a serious complication. With our procedure, we've not had any complications. It's very safe. And with artificial discs, they have a high complication rate as well. So why have surgery that you have such a high chance of getting a complication if you don't need to? And that's why we're broadcasting these surgeries. We want people to be aware there is a better way to do this. Go ahead.
This question from Renz on Facebook asking, "Hi Doc, good morning.
Morning.
Should I consider steroid injection my first since I have a disc extrusion on my C2-3? As for my EMG NCV, they only test from my C4 to C6. They cannot test the C2 to C3 disc because it's closer to the brain. So my doctor said I need to do the steroid injection first so that my doctor knows the correct disc he needs to work on."
Well, Ren, great point, great talk, great conversation. First of all, they are correct. There's no way to use an EMG conduction study to test nerve roots, which are pinched nerves higher up. But understand something, pinched nerves do not cause neck pain. Pinched nerves do not cause neck pain. So unpinching your nerve will never fix your neck pain, ever. If you're having neck pain or headaches from your neck going up, then it has nothing to do with pinched nerves. It has to do with inflammation within the tear in the back of your disc, okay, or it has to do with your facet joints. The facet joints are the second most common cause of neck pain. So once again, neck pain doesn't come from pinched nerves. It comes from discogenic neck pain, which is inflammation right here where I'm working, literally right here. It's a millimeter, actually it's a few millimeters of area up and down, and then side to side it's about 20 millimeters, okay? So it's a small zone in the back of the disc that we are doing our debridement. That's how you get rid of neck pain and headaches and pain going from your neck into your shoulders. Now, if you want to fix radiculopathy or myelopathy, you do the same thing we're doing right now. We go in here and we get the herniation off the spinal cord. You see this herniation right here? That is literally sitting on the spinal cord. It's not just herniation, it's scar tissue and it's bone spur. You see the gold color? Everything gold is bone spur, okay, osteophyte. Some of them are bigger, some of them are smaller. Here's herniation, the blue stuff. The white stuff is scar tissue. The gold stuff is calcium. It's part of the osteophyte. So you do not need epidural. Epidural is not a bad idea for your problem if you're having neck and arm symptoms. An epidural is okay, but it's not going to fix you. So my feeling about treatments that won't fix you when there's a treatment that will fix you is why? Why do a treatment that will not fix your problem when you can do a treatment that will fix your problem? Now, you may have your reasons. Oh, my insurance requires it. This is all scar tissue right here. A band of thick scar tissue from chronic inflammation. Look how it's calcified. This is horrible stuff. This is where the pain is coming from. You need this surgery, my friend. And I'm not saying you need it at C2-3 because I don't know what's causing your symptoms. I'm not going to assume it's C2-3. I don't assume anything. I always verify information. Just because your MRI shows a C2-3 herniation doesn't mean it's causing symptoms. I've seen tons of C2-3 herniations that never cause symptoms, and I don't operate on them. I don't recommend treatment. So you need an honest diagnosis, and the way you get that, Henry will show you. You do a free MRI review with me, okay? There's no obligation. You don't have to pay for it unless it's your more than one that you're getting, but you get one free MRI review. You just have to submit your images and your report and fill out our questionnaire about your pain. We don't do any advertising. We don't sell your data to anybody. We literally do it to help people like you get a diagnosis and a recommended treatment plan, okay? And although we're not perfect on Zoom, this is how we do it. We do a Zoom. We're pretty good. We usually get all the diagnoses about 80% of the time. And sometimes people show up and they have something that we didn't pick up on the Zoom call, which is fine. You know, we have to do additional treatment on that. And some people understand that and some people don't. So point is, we will diagnose the source of your symptoms if you give us a chance. That would be my advice. This is all scar tissue from chronic inflammation right here. This is an older injury for this patient. Remember, this patient is from Trinidad, and I can tell you he's a scuba diver. We had a nice talk about that. He's going to watch his surgery someday and appreciate the fact we're talking about it. He's very interested in coral reef preservation and ecology, and I told him I've done research. There's a herniation right there. Look at that thing. All right? Look how scarred down it is. It just won't come out. And it's full of calcium too. So scar tissue, herniation, calcium, all mixed together. Hopefully I answered your question. But you can do the epidural. I wouldn't recommend it. I recommend getting your neck fixed here at Deuk Spine. All right, Henry, other questions?
This next question coming from, forgive me if I've mispronounced this name, Valnilli on YouTube.
Millie Vanilli?
Valnilli on YouTube.
Valnilli, welcome.
Asking, will this patient be able to do yoga and play sports as normal without reherniating the discs?
Yes, this patient will take this disc right here where we're fixing will take 12 months for the body to heal this, okay? The reason why he has not been able to heal this area is because the herniation was sitting here, causing the body to react and would not allow the annulus to close. Okay, it's like somebody coming to your house, knocking on your door, you open the door, and then you realize, oh, I didn't want to talk to this person. You try to close the door, but they put their leg inside the door, and then you can't close it. All right? So now you got to get rid of the leg. Otherwise, you can't close the door. So you ask them to move the leg, but they won't move it. No, you can't close the door. So what I'm doing is I'm coming in and removing the herniation that's stuck in the tear, and that's going to let the tear heal. Once the tear heals, which takes 12 months, then you can do yoga. I mean, you can do yoga before that. You can do yoga in 3 months. Okay? You can do... I'll tell you a story. We had a patient who had this done. He went deep sea fishing, caught a 100-pound grouper. 100 pounds, 6 weeks after surgery. I told him maximum 25 pounds for the first 6 weeks. He went deep sea fishing, caught a 100-pound grouper, and reeled it in, and then held it for pictures. You know, remember him? Yeah. And he re-herniated. So he got another herniation before the disc sealed. So we had to redo his surgery. Okay? He's doing great. Yeah. He's doing great. But the point is, you know, lifting heavy things, playing contact sports too soon, that's going to ruin the work that we're doing here. You've got to let your body heal this area. It takes time. This is all scar tissue right here. All scar tissue. And bone spur. This is all scarred up posterior longitudinal ligament that's been damaged by the trauma and inflammation. All right, that's a bone spur. People ask me, can you get rid of bone spurs? I'm doing it right now. That gold thing is a bone spur. Not hard to do with a laser. Remember, these lasers are used to cut steel all the time in manufacturing. So cutting a bone spur is easy. Steel is much harder than bone spur. Almost done with this disc, about another 2 minutes on this disc, Dr. Berndes. Other questions there, Henry?
No current questions, but we do have a comment from Renz once more on Facebook saying, thank you, Doc. I will send my MRI now and will send my symptoms too. Thanks again for your advice.
You are welcome. My pleasure. That's why we're here, folks. I've seen so many horror stories of people not able to get the right diagnosis, not able to get the right treatment, having treatment that's completely unnecessary, like fusions or laminectomies that harm their bodies and cause more pain and suffering. So I made it my mission in life to educate people about how to properly treat spine problems that are degenerative. I don't deal with tumors. I don't deal with infections. I don't deal with tuberculosis of the spine. I deal with degenerative spine conditions, and that's what we're really good at. That's your disc problems, your facet problems, which is 95% of spine care today in the world. 95% of spine problems are degenerative. 5% are infection, tumor, trauma. And I don't deal with those. I'm not the best. Could I take a tumor out? Possibly. I mean, yes, of course I can. I'm a neurosurgeon. That's what we're trained to do. But I'm not the best in the world at taking tumors out of people's spines. Am I the best at trauma? Absolutely not. Am I the best at infection? No. But are we the best at degenerative? Absolutely we are. It's always good. Clint Eastwood once said, a man's got to know his limits. Yeah, we've treated some. I don't want to promote that we treat infections. Like, you know, the typical infections of spines are like osteomyelitis with fracture, deformity, instability. Sure, I can do the surgery, but the reality is that I don't do all the coordination of care with the infectious disease team and, you know, the follow-up. We just don't. That's not our focus. We're a focus factory. We primarily focus on degenerative spine problems and orthopedics. Any other questions?
Yes, we have a lot of questions now. This next one coming from Darren on YouTube.
Hi, Darren.
saying my 11-year-old daughter is having constant thoracic spine
Yeah.
back pain. Doc thinks it's scoliosis. You said scoliosis doesn't cause pain. What are your thoughts?
100% not scoliosis unless she has like a 45-degree curve. But at 11, I highly doubt she has a 45-degree curve or higher. Could be 50, 60. I mean, you'd have to have a major, major curvature to have pain. Like probably 50, 60 degrees of curvature or higher. But I say 45 is a threshold because I have a feeling she probably has like 10 or 15 degrees. Anyway, that said, it is not the scoliosis that's causing her pain. It is a disc problem, I bet you, and we can fix it with our laser surgery. So when you're ready, you do an MRI review and I will tell you why she has pain. And if it's the disc or facets, we'll fix it. And she'll be very happy the rest of her life. Okay? Yeah, you're touching on a very important point. What was this person's name?
Darren.
Darren?
Darren, correct.
So Darren, the problem is what's called misdiagnosis, right? Now, she has scoliosis, so they're correct. But the source of her symptoms is not the scoliosis. That's where the misdiagnosis lies, is in the ascribing of symptoms to the wrong diagnosis, right? And that is really comes down to what's called bias and ignorance. Bias and ignorance. And we all know bias and ignorance are bad things. Bad things, right? If you have bias and ignorance guiding you, you're going to make the wrong determination. And what's wrong? Oh, okay, yeah. Just about done. 30 seconds here. I just found a piece of herniation, so that's why it's taking me longer. All right. My advice to you, Darren, is get your daughter to do an MRI review with me. Okay? And just for those of you who don't know, an MRI review is not, I don't just look at your MRI. I actually examine the patient on Zoom and figure out what's wrong. And it really does take an examination. I can't do it without an examination. I have to see where the pain is. I have to have you push on her back a little bit, certain areas, to figure out if there's tenderness. But I can use my knowledge of anatomy and my experience of treating these conditions to make a determination of what causes her pain. So I promise you, unless she's got a big curve, it's not her scoliosis. I can't tell you how many people with scoliosis that I've cured their pain with non-scoliosis surgery. In other words, surgery that doesn't address their scoliosis. Okay? For what? Tethered cord. God. Dr. Davis, you're a good man thinking outside the box, but I assure you she doesn't have a tethered cord. Tethered cord doesn't cause usually back pain. It causes, orthopedic deformity, bladder and bowel incontinence are issues, and weakness in the legs. But it rarely causes pain. And it's easy to diagnose on an MRI. So, all right. Great questions so far. Once again, we're going to be moving, packing up and moving. So we fixed 2 out of 3 discs. We got 1 more to go. All right, here we go. You ready, Luis? A little pressure. All right, I'm going to leave the dilator shot. Dilator is the pointy thing, and I'm going to take out the tube. It's called a working channel or tubular retractor or endoscopic sheath, or as I like to say, the metal McDonald's shake straw. Great. Remember, everything we're doing here is FDA approved and peer reviewed and published. It's not experimental. We've been doing it for 18 years here at Deuk Spine. Huh? No, just keep them straight. All right. So at this point, I've got to move up 2 discs, right? Because we did the one above, we did this one. Look how well preserved the discs are, by the way. That's why this patient doesn't need any kind of artificial disc or metal. We're going up. So I'm going to pop out a 5-6. And I can tell you, hold on, I should be out right now. Yep. And I'm going to move up 2 discs. So shot. I got to make sure I stay in the middle while I do this. I don't want to be off to the side, left or right. That could be really bad for the patient. Really bad. Like, you just don't want to do that ever. So you want to just take your time and check to make sure you stay in the middle. Keep going, lateral. All right, I feel like I just popped back in the hole for the one I did. And I did. So now I'm going to go up 1 more disc. All right, I should be out. Right on the edge. Right there, I'm out good. And stay there for a second. Yeah, give me an AP. I'm going to stay here. And I'm going to check my front back positioning. He's straight up, right? No rotation. Yeah, don't extend him. Just de-rotate him. That looks good. Yeah, I mean, yeah. All right, hold on there, Jordan. All right, shot. So I just corrected a little bit, but I overcorrected. Shot. That's midline right there. That's perfect. Let's go up a little more. We should be done. So I'm going to fix 1 more disc. You can see there's a little scoliosis at the next level. Jordan, show us that before we take another picture. Look at how there's some curvature between that one and that one below. There's a little bit of curvature and then the one down below. Again, we're not doing anything with degenerative scoliosis. It doesn't need to be fixed. It's not causing symptoms. We're just going to go in and fix the pain. Radicular symptoms, shoulder pain. Give me a second. Shot. All right, so give me an AP. I want to make sure I'm in the middle. I feel like I'm off a little bit. Let's just see where we are. 2, 3, 4. Yeah, we're off. And shot. That's better, but let's see. I may have not be over the disc. Shot. Let's just see where that is. Perfect. Now give me a lateral. Let's see if we're over the disc. Not an easy case. I've had much easier cases. He told me he was going to be easy. I'm just kidding. He didn't. Shot. I'm giving him a hard time. He's going to watch the video and laugh, hopefully. All right, AP. I'll take your questions in a moment. Henry, let's show the audience how facet joint pain, the second most common cause of neck pain, it accounts for 10%. Yeah, see, we moved too much. How facet joint pain, that's perfect, lateral, causes neck pain. Well, we're finishing up localizing here. All right, you can see from that video we just created recently that the facet joint, which is located in the back of the neck, can cause pain when it's damaged. And the way it does that, shot, is it gets injured and then it gets inflammation just like the back of the disc, and that inflammation causes pain. And facets are particularly bad with neck pain, with rotation and extension. And the reason for that is they move a lot when you rotate and extend. So you're kind of like aggravating a painful joint with rotation extension. So if you have rotational pain, you probably have facet pain, especially if it's on the left or right, not dead center. If your pain is dead center, then it's probably disc. Most pain is disc. About 85 to 90% of neck pain is disc related, like this patient. But about 10 to 15%, it's related not to the disc, but instead to the facet. Now, most patients have both. We found that about 50% of our patients have disc pain and facet pain. And even if they didn't have facet pain when they showed up, they ended up getting facet pain later on. So about 40% of patients have both, disc and 40% have disc and facet, and 25% have both upon presentation. That means when they show up, they have both. But the other 25% develop it later. All right, how's he doing? Doing good, all right. So I'm slowly advancing this tube, and the reason it's going so slow is this disc is pretty scarred up. So I would love to get a little inline traction on this one.
Sure.
I'm going to ask my anesthesiologist to help me. He's going to give me a little distraction. Tell me when. Okay, shot. All right, we're going to keep a close eye on the dilator. So this disc is interesting because it's so scarred down that I'm having a hard time getting our tube in. You can hear the clanking. Remember the last disc we looked at? Huh? I see it. I see it. Yeah, but I'm not happy with that. Give me a second. I'm going to pull my dilator back just a little bit. Can we do that, shot? I don't want it going any further in. I'll hold the tube just a little bit.
There you go.
Shot. More. Shot. That's good. Now the good thing about the dilator is since you only need the dilator part that's where the tube is about to advance to. The rest of it, you can pull it back and save it for later, so to speak. There's no sense in jeopardizing the patient. Shot. So. Again, the dilator is moving forward with the tube, so let's pull back again. If you remember the last disc, there was a lot of scar tissue, and that scar tissue from chronic inflammation, that's good. That scar tissue is what's holding the bones together and keeping me from spreading them as I go in with this tube. That makes sense. Yeah. Oh yeah, no. Yeah, we're almost done, almost done. I want to move the dilator in because it came back. So sometimes the scar tissue will push the dilator back into the tube, okay? And the reason for that is the dilator will hit the scar tissue and get pushed backwards. Scar tissue can be like an elastic rubber band. Almost done. That should be it. I want a millimeter more. Perfect. That's good. I'm happy with that. Okay, so everybody see the incision, 4 millimeters. When we're done, we're going to wake this patient up here. He's going to go home, in his case, back to the hotel overnight. Then he's going to go back home tomorrow. Point is, this is outpatient. There's no hospitalization with this surgery. If you're having ACDF, most likely you're going to the hospital. Who wants to go to the hospital? Hospital is where complications happen. It's so true. When I was going to the hospital with my patients, they would get complications. And they weren't from me. They were from, I hate to say it, the anesthesiologist. Not my anesthesiologist, Dr. B, but the nurse anesthetist at the hospital. You see, the hospital was trying to save money, so they hired nurse anesthetists. They fired all the anesthesiologists. And when they did that, yeah, they saved money, but they created all these complications in patients that shouldn't have complications. I would have patients with pneumonia almost every surgery, every other surgery. They'd have pneumonia. They'd have infections. They'd have all kinds of problems. Edema, blood clots sometimes. I mean, not often, thank God, but the complications were a result of poor anesthesia. That's why having a good anesthesiologist is so important. At the hospital, they don't give you a choice what anesthesiologist you're going to use, because they just tell you, here, you're getting this person for today, this nurse. And it's like, wait a second, I don't like that nurse. And then suddenly you're the bad guy because you're asking for a different nurse. And then they start talking to each other and you're Satan because you want a better nurse for your patient. You want no complications for your patient. They don't care, you know. I hate to say this. The truth is, hospitals make more money on complications. Okay? Your bill for a fusion could be $250,000 from a hospital, but when you have a complication, oh man, you can make millions on that patient from their insurance. Okay? No, hospitals are not bad. Okay? They're not bad, but they're unnecessary and they can create additional risk for the patient. Look at all this scar tissue right here. It's getting calcified, it's golden, it's stuck down from the disc into the spinal cord area. So this is what this poor patient's been suffering with. Now, I could tell you right now, this is about 20 years old or 30 years old, okay? There's more herniation right there. So there's a combination of old herniation with scar tissue and calcium and bone spur and new herniation. This is the new stuff right here. Questions? By the way, that's a tear in the posterior longitudinal ligament. You can actually, the spinal cord is right below that. So we're going to be super careful. Here's herniation, scarred up. We're removing the herniation, but we're not going to, see how the scar tissue goes down into the spinal canal? Right where the spinal cord is. It grows right off of this area here. This is why you want this surgery, folks. No ACDF, artificial disc surgeon can see this. They've never seen this in their entire career. I have the very best microscope in the world, okay? The very best. And I use it for my ACDFs when I do them. And you cannot see this level of detail that you can see arthroscopically. Arthroscopically is so much better than microscopically when it comes to these surgeries. So the truth is, most spine surgeons don't even use a microscope. They're blind back here. There's a herniation, by the way. We will never do an ACDF blind. I always use a Zeiss NC5 microscope, which is the top of the line in the world, best optics, best microscope. And I can't see anything of this stuff with the NC5 microscope. It doesn't show enough. But an endoscope is 10 times better. And because the surgeon can see 10 times more detail, we can be 10 times more precise. And the laser is the tool you use when you want to be precise. All right, so very cool imagery. Very cool, very cool. I love it. I'm not going down there because I don't see a herniation, and I'm not going to mess with the spinal cord. Okay? Any questions?
Yes, we have a couple questions. This next one coming from Diane on YouTube.
5 minutes, Dr. B. Go ahead, Diane, on YouTube.
Asking, what's the risk of reoccurrence/herniation, and what is the recovery timeline like versus traditional discectomy?
So traditional discectomy, you're going to get different recovery times from different surgeons. It depends on what recovery means. There's another herniation right there. But let's just say ACDF recovery is 3 to 6 months. With this surgery, recovery is 3 to 6 days. So basically 1 week. Another herniation. So 1 week for Deuk laser disc repair versus 3 to 6 months, let's say 6 months for ACDF, if you recover with ACDF. And then the other question was, by the way, the recovery today, he's going to be here for 2 hours in recovery, waking up, and then he's going to go back to his home. In his case, since he lives in Trinidad, he's traveled to Florida for the surgery, he's going to go to his hotel. Why do medical tourism? Well, the obvious answer is to get better care. And that's what he's done, okay? Trinidad is a wonderful island, I'm sure, but they don't have the services that every patient needs. So this is an example. As a matter of fact, New York City doesn't even have this service available. This is the only place in the United States you can go to get endoscopic cervical spine surgery done with Deuk laser disc repair procedure, which is the best treatment, by the way. Next question.
Next question coming from
4 minutes.
Renz, once more on Facebook,
Hello, Renz.
asking, Doc, if I have occipital neuralgia due to neck pain, what is your advice? What usual treatment do you require?
Yeah, Renz, great question. So first of all, if you were my patient, I would want to confirm you have occipital neuralgia. And the way we do that is we do an occipital nerve block. We numb up the occipital nerve and see if it takes away your symptoms. If it does, and we've confirmed that you have occipital neuralgia, then the next step is to burn that nerve with what's called the Deuk plasma rhizotomy. And that's something that I developed here at Deuk Spine. It's a permanent fix for your problem. That's what I would do. All right, so here I had to expose the spinal cord because the herniation was going down right onto it. So I had to release some of the fibers from the PLL to get rid of the herniation, okay? But I'm done on this side, a little bit of scar tissue here. Next question.
Next question coming from Crystal on YouTube,
Hi, Crystal on YouTube, welcome.
saying, I'm sorry, I'm not sure if this was mentioned previously and I missed it, but what may have caused the inflammation, scar tissues, and bone spurs, etc.?
Yeah, Crystal, so great question. It's the same thing for every human being on Earth that has a herniated, degenerated, ruptured, protruded, extruded, slipped disc. Any kind of disc problem, it's always the same. And that is, number one, trauma. You need trauma. You need an accident, fall, car accident, sports injury, you name it. That causes a sudden loading of your spine, which then tears the back of your disc, called an annular tear. Once you have an annular tear, now the herniation is going to come out through the tear, and it gets stuck inside the tear because the tear is thick. So we call that the annular wall, and the herniation right here gets stuck. This is the herniation. And then once it's stuck, it creates inflammation. Your body tries attacking it, getting rid of it, but it can't because the herniation just won't go away. It just stays there, and it creates more and more inflammation. What I'm doing is I'm removing the herniation, I'm removing the inflammation, the scar tissue, and the bone spurs that need to be removed to let your disc heal. I pioneered this technology here at Deuk Spine 18 years ago, using the endoscopic techniques I learned overseas in Germany and Korea. And I added the laser because the laser is really what's necessary to remove the scar tissue and bone spurs. The Koreans never used the laser at the time, and the German didn't either. Dr. Sebastian Reuten. Great surgeon, by the way. Really like Dr. Reuten a lot. But he used just surgical instruments, and he's really moved away from just doing these to doing fusions. Why? Because his results were not good, and he decided to do fusions. So if you can't get good results without fusion, then you might want to consider fusion. Okay? But our surgery works. You don't need fusion. That said, I've done 1,000 ACDF fusions in my own career, and artificial discs. ACDF artificial discs. 2 minutes. So we're just about finished. I'm just cleaning out the last foramen. This is the left 3-4, right? Left 3-4. So that would be the C4 nerve root that we're dealing with. Any more questions?
Yes, this next question coming from Sharif on YouTube,
Sharif.
asking, Doctor, where in Dubai could I get this done?
You cannot get this done in Dubai, Sharif. I'm sorry. You cannot. I want it to be done in Dubai. Introduce me to the king, and I will make it happen. Luis has got his bags packed. My team is ready to go. We all want to come visit Dubai. Okay? Point is, right? Point is, the truth is, it's not available in Dubai. It's not available at the Mayo Clinic. It's not available at, what's the other one in Dubai? I can't remember. Besides Mayo. Cleveland Clinic. They don't have it, guys. This is more advanced than anything they're doing. We are a small company, but we have discovered the secrets to fixing spines. All right. They have lots of Americans in Dubai. I don't, no, you have to be part. Dubai has made a deal with the Cleveland Clinic. They've made a deal with, big hospital systems in the United States. They're very powerful. And the people in Dubai are getting the same kind of treatments we're getting in the United States, which is fusions and artificial disc. But those are old-fashioned treatment. And they're not getting the newest, most advanced treatment. Yeah, you cannot get this in Dubai. There's nobody in Dubai that does this. Dubai is pretty much closed to outsiders like us. But if you can get the king to approve our visit, we'll train some people over there so they can start doing it in Dubai. It's not hard. It'll take probably a year of training for me to train a neurosurgeon. And then you guys don't have to go anywhere. You just stay in Dubai. Okay? I'm happy to do it. We are done. I'm taking the tube out. We finished all 3 discs with 1 tube and 1 incision. We lost literally 5 drops of blood. 5 drops. Now, 20 drops makes 1 cc, 1 mil. ACDF, if we did ACDF, not me, but other surgeons, they lose 50 to 100 milliliter. We lost 0.25, 0.25 mil. So this is bloodless surgery. There's no narcotic painkiller after the surgery. After ACDF, you have to take, opioid narcotics, dangerous drugs for pain, because the surgery is so damaging to your body. This surgery, no narcotics, no painkillers, none. All right, I'm going to come in and answer questions. I'd like you to show the video on facet, Deuk plasma rhizotomy, cervical. Yes.
Copy that.
Scope use is going to be a 7. Not ready.
Facet joint injury is a common cause of chronic neck pain. The inflamed facet capsule tear generates pain signals. The best treatment for facet joint pain is the Deuk plasma rhizotomy. The inflamed facet joint pain nerves are destroyed. The advantages with the Deuk plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Dr. Deuk Majan, CEO and founder of Deuk Spine Institute, Deuk Joint Institute. I'm here with our patient from
Louisiana.
That's right. I had to have him say it. It sounds better when he says it. Why did you come all the way to Florida to the Deuk Spine Institute?
Well, about 3 months ago, I was scheduled for a cervical disc fusion in Shreveport, Louisiana. Had done all the pre-op stuff, was scheduled within 2 weeks to do the surgery, got to work and started doing some research. The more I read about what they were going to do with the fusion, people having trouble with it down the road, above and below the fusion, decided there had to be a better option. So that's when I found Dr. Deuk and his team and started watching some of his videos. Pretty impressive.
And you're a YouTube guy, you were
Yes,
telling
sir.
me, so you found us on YouTube, and what did you think?
Well, our first impression was any doctor that will put his livelihood live on YouTube, showing all of his surgeries, putting it out there, believes in what he's doing. That's not many doctors would do that.
Not just because of that, but because, afraid of complications, which, praise God, we haven't had a complication. We've been doing it now for 17 years. I want people to know there's a safer, better way to take care of their problem other than metal, fusion, stimulators. That's really the message there. You got that message loud and clear.
I did. My surgery was less than 24 hours ago. So far, the tingling, numbing going down my arm is non-existent. It's went away where it was there constantly all the time before. So hopefully this continues on.
Oh, it's gonna continue on. Our results are permanent with the laser surgery. And you can see your tiny little incision right there. It's a 4 millimeter. You can see we went in with a little tube into your disc. I was able to get both discs fixed. You had a lot of herniations in there. Something a lot of people don't understand. They think that a herniation is one piece, but it's about 30 pieces on average. And you had about 30 pieces in each of your discs. They were hard to get to, but we got it done. And I was very happy with the end results. We got all the pressure off the nerves, and we fixed the tear in the back of the disc. Less than 24 hours, here you are. You're doing fantastic. Now, what did your wife think about you coming down here to Florida? Was she supportive?
She was. This problem had been going on for many years. Started out on my right side years ago and had some stuff fixing that, but she knew the problem I was having. I'm very active. I'm a scuba diver, a motocross racer, do a lot of active sports, and she said, we've got to get this fixed. I'm too active still to actually quit all this. I don't want to quit, so this fusion just seemed like it was going to limit my options on doing things. So that's why we come down here. She was very supportive, and we decided to sign up and come on down.
What do you have to say to your insurance company? What do you want them to do?
I sure hope they pay, because I know they would have paid on the fusion deal, but why they would not pay on this, I don't know why, because results are immediate.
And no narcotics?
No, haven't taken a pain pill, haven't taken anything, nothing. Slept like a baby last night.
That's right. And after fusions, a lot of patients end up in pain management. They're getting shots, they're getting pills.
They can't talk, their esophagus is all tore up from them pushing it out of the way.
That's right.
And I have none of that.
Yeah, our patients don't go to pain management because they don't need it. Anything else you want to say to your fans out there?
If you are considering having some type of neck or back surgery, I think you ought to look at Dr. Deuk and his group, because they got a great facility down here, very accommodating. They'll help you with travel, whatever you need. We flew down Sunday, today's Wednesday, and we're going to stay till Sunday. Enjoy a little bit of Space Coast. Hopefully get to see a rocket launch here on Friday morning.
That's right. You can see the rocket launches from here and feel them. All right, sir. It's a pleasure.
Thank you, sir.
My pleasure. You have a great day.
Okay.
Let's get you guys out of here. You got better things to do than to sit in a doctor's
Exactly.
office. I'm here with my patient who traveled from California, Northern California. He had a herniated disc at C5-6. It was a small disc bulge. He was told by the doctors in California that he should just live with the pain, give it time, and eventually he'll need a fusion. Is that right?
That is correct. I was told that within 5 years I would be needing surgery. So basically what they were saying, live with pain for 5 more years and then we'll do something about it. One of the things that I've seen a lot of the videos is testimonials, and I will always say, this doctor sounds too good to be true. And actually it is true. I appreciate you, doctor. I really think that is really nice procedure, and the staff here is really nice. They're always very friendly and kind to get you through the process, because when you get told so many times that that's your new life, it's kind of, you're always thinking, is really the way I want to live? If I'm going to live a lot of years, why wait with pain? You know, you need to do something different. And always, whenever you see videos, you're always a little sketchy and saying, maybe it's not true. Maybe this is not what it is really saying. But today, when I felt with no numbness and no pain on the neck and just going through the process, I really been blessed. I'll be flying to California today. I honestly can't say much. You know, it's a miracle. Whenever I heard the testimonials, they say you're a tool for God. It actually seems like that's the way it is. It's a miracle through you. God works through you, and it's awesome to feel better, you know?
I'm so happy for you and your lovely wife who's here with you. You can see you had a tiny little incision. You had the Deuk laser disc repair for your herniated disc. You can see we were in there with the laser, cleaning out that foramen on the right side where the nerve was being pinched. There were a lot of pieces of herniation in there. And the laser cleaned them all out, and your surgery went perfect, and here you are less than 24 hours later. Feeling good, huh?
Well,
With a smile on your face. That's what I like to see.
You know, it's a smile of happiness. It's a smile of joy, you know, that it is doable. And I think no one should be able to be living with pain. I was so happy to see testimonials when they used to say, well, the one regret I have is not going in earlier and living 18, 20 years with pain. For me, it's been 3 years since July of 2020. It's been miserable because I've been with pain. And I've been told by doctors, let's just take time. I did all kinds of physical therapy, acupuncture, you name it, everything that's out there, and nothing seemed to help. And today, with one day of getting something really that's gonna be for life, it's amazing. It's a smile of joy, you know? If you are going through this trouble, don't hesitate on sending your MRI. When I did it, I sent my MRI for free review, and my answer was, yes, you are a candidate. Here I am today, flying back with literally no pain on my neck and no numbness on my hand, which I miss that. That's awesome.
It's wonderful. Now, what is your native tongue? What is your native language?
It's Spanish.
Are you from Mexico originally?
Guadalajara, Jalisco, Mexico.
Guadalajara.
Yes.
One of my favorite songs. Can you tell them in your native tongue how you feel?
Yeah. Quisiera decirles que si están teniendo problemas con una hernia en su cuerpo, manden su MRI, es gratis y les van a dar un resultado, una verificación si ustedes son candidatos. No vivan con dolor, porque el dolor les va a causar toda la vida, y los doctores allá afuera les dicen que no hay solución, pero las soluciones existen, simplemente las tienes que buscar y creer, tener fe que tú vas a estar mejor. Si Dios te mandó a este mundo es para que vivas bien, no para que vivas con dolor. Así que te recomiendo que por favor tomes esto en serio, hagas ese paso de mandar tu MRI gratis y habla ya sea con quien tengas que hablar para que ellos te empiezan a guiar y te digan qué es el siguiente paso que tienes que tomar. Así que una recomendación con Dr. Deuk. Muchas gracias.
Muchas gracias, amigo. And Feliz Navidad.
Feliz Navidad. Gracias.
Safe travels, my friend. Thank you so much for sharing.